Welcome back, everybody. In this lecture, we're going to continue on our journey of exploring clinical psychology. As you've probably noticed, we've already taken a couple of turns on this topic, and we'll continue to do so not only in this lecture, but in some of the continuing ones when we look at one of the most commonly explored areas of psychology today. In this lecture, we're going to focus in on a specific component to clinical psychology, what we call mental health approaches. And to understand what it is we're going to address, let's start this lecture off by providing a little bit of context. In our previous classes, we've spent a lot of time focusing on kind of historical trends transitioning into current trends that focus on how clinical psychology, or what we used to call abnormal psychology, was both interpreted and explained, not only within our current culture, but across numerous cultures over various centuries. And this attempt to look at some of these historical perspectives was not only done to give us a better sense of all the different things that exist and beliefs that exist today surrounding clinical psychology that seem sort of unfounded if we look at it from a scientific perspective, it also gave us the ability to get into some of the stuff we're going to be talking about in this lecture. Because much like we had to go through an evolution in thinking of what the causes of mental health were, how we actually explained things, and also, as we talked about in the last class, how we categorize different mental health issues, we've gone through this same type of evolution when we talk about how to treat and help individuals. And in fact, one would probably contend that this is a specific area within clinical psychology that we're still grappling with today, trying to find ways to better understand and tweak some of the approaches that are more commonplace in our society. And much like we did in our last class when talking about trends in the past, when we talked about how to define mental health issues and transitioned to kind of what clinical psychologists are doing today, we're going to take that same journey when talking about different approaches to mental health. And this is where we get to sort of an evolution, not just trying to understand why people were struggling with mental health problems, but how we could help these people that were now deemed as potentially, well, necessarily repairable, because it has a weird connotation to it, but people who were kind of capable of getting back on the track that they were on. Much like we had to go through an evolution in our thinking of where mental health problems were coming from, we also found ourselves having to go through many evolutions and trying to help people with the multitude of problems they struggled with. If we look at our early attempts to try to fix problems or help people with challenges they were going through, a lot of it was biological in nature. We didn't quite understand how or why the brain was linked to mental health issues, but when Freud and others started to suggest that many mental health issues were linked to the mind, and the mind was inevitably linked to the brain, we came to the conclusion that just tinkering with the brain could potentially help people with their mental problems. So things like psychosurgeries became not necessarily commonplace, but suggested forms of treatment for people who had very severe mental health challenges. Things like lobotomies, other types of kind of clippings of portions of the brain to try to help with different specific ailments became things that were suggested for large numbers of individuals in the population, and unfortunately, large numbers of surgeries like this started to occur in the 1800s and 1900s as we transitioned to kind of a more biological analysis of where mental health could come from. It also led to kind of unfounded, unusual, but still even to this day persistent ideas that things like electrocuting the brain could help individuals with problems, or trying to find ways to reset cellular connections could fix a person's problems that they were struggling with. Eventually, these kind of blunt instrument attempts to try to help people with mental health problems gave way to more nuanced biological approaches that we have today. If we look at today's attempts to try to help people with mental health problems, usually, if we're talking about the biological side of things, focuses on addressing things on the cellular level. And this is where we get into some of the more prominent medications that are prescribed today. When people are given medications for mental health issues, we're operating on the assumption, much like we've been for many years, that there are structural things that are causing or at least linked to some of the mental health issues that people are struggling with. Medications are designed specifically to help on the cellular level with these issues. We've talked in previous classes about how certain medications can get neurons to communicate with each other more, or get neurons to communicate with each other less, or potentially even create new bonds, new connections with different cells. Now, many medications in the mental health world try to do just this, trying to specifically address different parts of the brain that have been tied to different types of problems. And if we look at the medication approaches that we've developed over the years, it is important to note that many of the medications devised have proven to be very effective tools in helping people with a large range of different mental health issues. Oftentimes, people will see relatively quick responses to certain types of drugs, and responses that hit not just one specific problem that somebody's struggling with, but maybe a wide range of mental health issues related. And as we celebrate medication, many psychologists and biologists alike have started to question the merit of some of the medications that we're overusing in our world right now. Many psychologists have suggested that many people struggling with mental health issues could easily be fixed through talk therapy. Not fixed, I don't like that word. It easily be helped through talk therapy, or kind of be allowed to kind of get themselves through specific problems without needing medication. But since medication is so abundant, so easy to prescribe, these people find themselves getting prescriptions for things and feeling like they sort of need to use these things. Now, there are differences between recreational drugs and drugs linked to mental health problems, but there are still people who can become both psychologically and physically addicted to certain drugs that they're taking for mental health. And there are issues with tolerance as well, as we continue to take these drugs and require more and more to produce the same mental health effects that we've seen. And this has led many people to ask whether or not what we're doing here is actually helping individuals with their problems, or just masking the manifestations of the symptoms linked to the problems that they've developed. One of the kind of best analogies I've ever heard from somebody trying to kind of equate these problems to others that we might encounter is one where we talk about somebody having, say, a car that's leaking, that's dropping oil all over the ground. Right? A good mechanic, if you take your car to that person, might tell you that one of the good ways to help your car continue to thrive is to put some oil in the car, make sure it still needs it. Very few people would probably trust a mechanic who says that's all you need to do. And a good mechanic would look for the things that are causing the leaks, look for ways to help get the car back to being more efficient. And this is sort of what many psychologists and even biologists have proposed with medication. If we want to fix somebody's issues, if we could potentially fix an issue, if we want to just help somebody, I guess we should say, it might not be sufficient just to give them medication and assume that everything's going to go away. Instead, it might require sort of a combination of medication and some type of talk therapy, or something else that kind of helps with whatever was causing some of the issues in the first place. And this debate, this conversation, is something that is still persistent in today's clinical psychology. And if you get into the field, you'll very likely encounter this conversation much more. But it's also important to note that there are other heated topics that are raging in psychology and biology today when it comes to mental health and how we might try to approach it from this biological perspective. One of the newest ideas that's been circulating for centuries but has really become prominent in today's clinical psychology is this notion that there could be inherited characteristics that we have that make us more inclined to developing specific mental health issues. Today's biologists have been able to trace back specific types of gene combinations to not necessarily a certain development of specific mental health issues, but a higher proclivity for developing specific issues. And this has led for researchers to start considering whether or not it would be ethical or logical to get people's genetic markers, do some type of genetic tracing, and then help individuals recognize the things that they might have a higher proclivity for developing issues with. This sort of brings us back to the diathesis stress model, where we could potentially decode somebody's diathesis a little bit better and help them maybe steer clear of specific stresses that could bring out specific problems. But as we get into this area and get sensitive, it could potentially create lots of pitfalls and problems. It could not only be potentially stigmatizing for individuals who are told they have a proclivity for developing something, but it could almost create this world where people feel like they're inevitably going to develop specific types of problems. And this feeling of hopelessness or of inevitability might be something that could exacerbate somebody's problems in a way that maybe not knowing that information wouldn't do. It's a tough topic. It's a challenging one. And, it gets into areas that transcend just psychology, where it starts to talk about ethics and other considerations for the individual that we didn't necessarily have to think about before we had a lot of the tools we have today. But it is, much like the medication debate, one of the concerns and issues that are being discussed when we get into mental health and how we can help people, at least on the biological side of things. But that doesn't mean that it's the only place where these debates are occurring. In addition to there being lots of questions about how we can help people on their biological side, there's also, still to this day, lots of questions about how to help people on the psychological side as well. And when we talk about helping people, again, not only with specific disorders, but just things that they want help with, whether behaviors or reactions that they want to overcome or things that they're wanting to work themselves through, what we're talking about here is something that we call psychotherapy, a type of treatment that focuses on the mental side of things in both disorders and, again, these day-to-day issues that people might want help with. And it's nested in the belief that many people who are struggling with things do have a mental component that's a major contributor to it, and not only that, but that addressing these mental components, finding ways to figure out the thoughts or behaviors or kind of internal things that are leading somebody somewhere, could be kind of the exact path we need to help people out of these problems. But even though there's an agreement amongst many clinical psychologists that this is an important factor, how we get at those thoughts, which specific thoughts we're getting at, and how we change those things is a source of great debate even today, almost 100 years after Freud started introducing his extremely controversial ideas that sort of were the framework for early clinical psychology, or at least early psychotherapy. It's important to note when we talk about Freud that his approach is just one of many nowadays. So what we have done since Freud talked about his ideas is really define exactly what his technique was. Nowadays, we call this approach psychoanalysis, and it involves a very intense exploration, usually of our childhood, our hidden thoughts, our attempts to get at the unconscious through a lot of very interactive, long-lasting tools that have been developed by people who have been trained under either the tutelage of Freud or, well, nowadays, areas that have kind of specialized in this psychoanalytic approach. Not all clinical psychologists have extensive training in psychoanalysis these days, and in fact some have flat out rejected a lot of the assumptions and approaches that are found within psychoanalysis. But if we're looking for a starting point and one to kind of contrast other approaches to, psychoanalysis is still, in clinical psychology, one of the ones we often start with. But since Freud's work, as I mentioned, there's lots of other things that have been developed along the way. One of the tools that's been developed, which sort of came as a direct reaction to the Freudian approach to studying the mind, is what we call the behavioral approach to clinical psychology. Its focus is almost, as the name implies, on just the observable changes in behavior that we can create, which theoretically, over the long run, could be used to change thoughts and emotions that people are internally experiencing. Many early psychologists who wanted to apply this behavioral approach to clinical psychology focused their attention on types of learning like classical and operant conditioning. There were actually many different examples of how these things could work, but one of the best examples that we've come across over the years is something called systematic desensitization. If we were in class, which obviously we're not in an in-person class, I'd be putting up a video right now that's about 10 minutes long showing a woman being systematically desensitized with her fear of snakes. In this video, she talks about how snakes have been something that have terrified her for years, and she can't even think about them, but through interactions with somebody that specialized in these behaviorist approaches, he's able to show her not only a snake, but eventually have her interact with this snake by the time the therapy session is done, highlighting the utility of this behavioral approach in at least specific situations like this. But it's important to note that as people started to approach this, or I guess explore this behavioral approach, we started to quickly identify that even though it could work in certain situations, it wasn't a fail-proof approach. It wasn't going to help everybody with every mental health issue they were struggling with. So many psychologists, as the field started to develop, looked for alternatives. Looked for something that wasn't part of just the psychoanalytic approach or the behavioral approach, and instead something that maybe fit a different formula or kind of helped people with other types of problems. And we found many options along the way. One of the options, which is used a lot in many different forms today, is something called cognitive behavioral therapy. This particular approach, or CBT, is one that tries to address, much like we talked about before, not just one thing, but multiple things that could be precursors to the development of mental health issues. CBT not only uses behavioral tools, like we've talked about, but it also looks at thoughts, looks at the emotions that people are feeling, to try to get at the sources of different problems, and in doing so, hopefully, to help people adjust these things so they can help with whatever their mental health issues are. CBT comes in many different forms. One of the first ones that was created was something called rational emotive behavior therapy, something that was actually championed by a gentleman named Albert Ellis, where we go into the reactions that people have in specific situations, assessing the thoughts and the feelings that they're experiencing at that moment, and really challenge them, dispute them, to try to help people with these things. But there's many other types that exist beyond just rational emotive behavioral therapy. And because of this, this tried and true technique that can change for different types of mental health issues has sort of become the gold standard for most clinical studies these days. It doesn't mean that it's the perfect approach for everybody in every situation, but what it does mean, much like when we're talking about gold, is that it's something that can be kind of compared against for every other thing that we're looking at. If we want to know how you can best help somebody with a specific type of problem, many researchers often compare CBT with some new treatment that somebody's developing, some new approach that could try to get at the problem from a different angle. And oftentimes, CBT works pretty well. There could be other techniques that work better for that problem. But It's been something that's not only been established for many years, but it's something that's so multifaceted that it seems to have a much wider range of efficacy compared to almost all the other approaches that we're going to cover in this class. But again, it's not always the perfect thing. In fact, another approach has been embraced by certain people and kind of accepted as maybe better for specific types of individuals. And this one is one we've actually talked about before, something called the humanistic approach, which, if you need a refresher on, was an idea that was developed by Carl Rogers a number of decades ago. His humanistic approach, which again can be applied to personality, is also something Rogers tried very hard to apply to clinical psychology as well. His research on selves and self-actualization and trying to create these positive environments for people are all parts of his humanistic approach to therapy. And in his attempts to try to help individuals through something he called client-centered therapy, he pushed creating environments that were very accepting and pushing people to reach their highest level through some type of kind of welcoming, loving environment that kind of nurtured that journey. Many small techniques in the humanistic approach are seen today in other types of clinical psychology as attempts to kind of mirror what clients were doing, not only in their behaviors, but what they're saying, is a persistent approach in a lot of different techniques that clinical psychologists use. His attempts to kind of create a bond with what he called clients, not patients, is still something that's a part of numerous different clinical approaches today. And it really highlights how some of our early ideas might not be in their pristine form like they were earlier. The same thing with the psychodynamic approach and with the behavioral approach, and even the social cognitive approach. But lots of nuances to them exist in specific techniques that clinical psychologists are working on every single day to try to help with specific problems that they're, more trained to work on. And this leads us to kind of how we've developed in recent years. We oftentimes, in clinical psychology today, don't encounter brand new revolutions that are popping up every few years. There aren't huge philosophical shifts that have really defined clinical psychology since the 1960s and 70s. Instead, what's really defined changes in the field is how the field's adapted to the environment that we find ourselves in, adapted to just the constraints that clinical psychologists have encountered. A great example of this is a very commonly used technique nowadays called brief therapy, where a clinical psychologist, or sometimes a psychiatrist, will try to help individuals with problems by talking with them for just a few minutes, trying to address what's happened over a long span of time, trying to come up with a game plan for how that person could help themselves. You might wonder why something like this would happen. Well, brief therapy is not necessarily the most effective tool that we've discovered over the years, but one that's sort of necessary as a result of things like limits on time, limits on how much somebody's able to spend on therapy, and limits on how much insurance is willing to cover for this specific health side of the world. Brief therapy is also often used in conjunction with some of the medical approaches that we talked about earlier. And when this is all taken into account, we might have a better sense of why this new approach, which isn't necessarily a philosophical change, but more a structural change, has become very popular in recent decades. This is also true for things like group therapy and self-help groups. Group therapy is when a therapist tries to help many individuals with similar problems at pretty much the same time. Self-help groups is when many individuals with the similar problems just try to help each other without having the guidance of some type of clinical psychologist or counselor that specializes in that area. Both types of approaches have their utility. There's some logic behind both of them. This notion that we can learn from each other and feel more interconnected when we're exploring our problems with others. But again, looking at efficacy rates, looking at these being shifts in thinking or just reactions to the environment, highlight how we haven't, again, shifted philosophically over the last couple decades, really, as much as we've just adjusted the times. Because both group therapy and self-help groups can be very effective ways of helping larger numbers of people and kind of doing it in a cost-effective, time-effective way as well. If we're looking for really the only major shift that I can really highlight over the years, it's this recognition by many clinical psychologists that not one size fits all. And in fact, more often than not, to help a person, many different sizes, many different approaches need to be combined to help with whatever problems a specific person is struggling with. And this has led to dramatic growth in something that nowadays is called integrative psychotherapy. Historically, you might see it called eclectic therapy as well, but that specific term has sort of been put by the wayside as people started to kind of link that with more of an unscientific attempt of just throwing everything at somebody. Today's integrative psychotherapist tends to train a lot in many different approaches in clinical psychology, not only while they're in graduate school, but also afterward, as they're continuing their education throughout their entire careers. And this allows these individuals, theoretically, to be more adaptive to the problems that people are struggling with, to kind of figuring out what fits the client or person that they're trying to help with. And theoretically, it can help them kind of adjust as new problems and new issues arise in the client-therapist relationship. There's lots of schools, actually, that have really tried to kind of do away with just training people in one approach and instead kind of incorporate this integrative psychotherapy approach into the education systems that they have. And it's created kind of a more well-rounded clinical psychology field that we have today, one that takes into account the medical side of things, the cognitive side of things, the emotional side of things, the structural side of things in ways that, well, maybe we hadn't been doing for a long period of time. And it's led to a very complicated field of clinical psychology. And this is where we're going to be going to next. Not just looking at the complications behind trying to help people, but all the different things that people can sometimes see clinical psychologists for. I do need to, again, caution you that now that we're done with this, we are not clinical psychologists. And in our next class, when we talk about mental health issues, we're not talking about all the mental health challenges that people could potentially struggle with. We're just looking at a few. But if you can kind of keep those things in mind and have a good understanding of this, we will hopefully in our next lecture, when we get into those specific mental health issues, we can learn a little bit more about clinical psychology. You can explore some of the challenges that people in this area are encountering on a regular basis. But for today, I think we've sort of reached the end. I hope all of you are doing well. I hope that we're all hanging in there as we get to the very end of the class. And hopefully, we'll see you soon. Until then, take care.